Taking a look at the leg now. Now, as you can see, we're going to move just a little distal for the knee and down towards the lower part of the body. What I really want you to do with this section is really look at the structure and then really go back and study that knee lecture, and then moving forward, take the information in the foot and ankle section, move backwards into this section, and move backwards even farther into the knee section. So what I really want you to gain is how many static and dynamic connections we're going to see between our hip, our knee, our lower leg, our foot, and our ankle. So just look at general considerations here. So we've looked at the popliteal fossa in the past. Also, we're going to look at a lot of those structures, both from a myology standpoint, a neuro standpoint, and a vascular standpoint. A lot of those structures are going to continue on. Okay, so for example, anterior tibial artery, the deep and superficial peroneal, or what's called the fibular nerves, those are going to pass. However, just understand where they're going to pass. Obviously, I've posted a lot of supplement video to help this lecture out, and the reason being is because we're going to see a lot of branching. This is very similar to what we saw in the elbow and what we saw in the hand and the wrist. So now looking at the osteology, understand when we're talking about weight-bearing bones and non-weight-bearing bones in the lower leg, the tibia bears weight. The fibula does not. Please understand that. Also understand, just like we saw with the radius and the ulna, we're going to have a proximal joint and we're going to have a distal joint. Now, the connecting membrane between the tibia and fibula is going to be called the interosseous membrane. That just means between bones. But understand that we're going to have two joints here. Obviously, the distal joint will form our formal ankle joint. Looking at the osteology here. Now, what we can see, we have a lot of stuff happening on this slide. Take this slide a little bit at a time. Move from left to right. Understand on the left-hand side of the screen, we're going to see the anterior aspect of the lower leg. Obviously, moving towards the middle, that's a cross section. Okay? Understand the difference between our thigh cross section and our lower leg cross section. Looking at the posterior aspect, we see a lot of differences as well. And then take a look at the actual distal joint between the fibula and the tibia. Notice how that joint is shaped, because that's going to really affect a lot of the arthrokinematics that we see at the foot and the ankle. Now, looking at the tibia, notice the inferior surface of the tibia. What we're going to see is the inferior surface of the tibia is going to contain the majority of that articulating surface. So the distal tibia articulates with the talus. This will form what's called the towel crural joint. Okay, and that's the technical term for your ankle joint. Moving on to the fibula. Remember, the fibula is the non-weight bearing bone. Tibia bears weight, fibula does not. Please understand the differences between the proximal fibula and the distal fibula. Understand what attaches at that proximal fibula. Things like the lateral collateral ligament. Those are going to be very important to understand as we start looking at the arthrokinematics and the motion of our knee and our ankle joint. Now, what we see here is looking at the fibula. Obviously, we've seen this picture before, a couple slides in the past, but take a look at that fibula. What I really want you to gain out of this is that my lateral malleolus, that distal termination of the fibula, sits just a little bit distal as compared to the distal tibia, or what's commonly known as the medial malleolus. That really plays into how much eversion and inversion we're going to have at our ankle. We'll get into those points later. But really understand how that relationship works. you should really look back to that forearm slide we did way last semester, because very, very similar relationship between my distal radius and my distal ulna. So now looking at the arthrology, obviously before we've looked at the tibiofemoral joint, we looked at the knee joint. Now what I really want you to focus on is that section where the tibia articulates with the fibula. That's going to be my proximal tibiofibular joint. Understand that we're going to have a proximal posterior and proximal anterior tibiofibular ligament. Again, says what it is what it says. Those ligaments are pretty easily named because they're literally named based on where they are. So looking at arthrology even farther, now we're looking at the distal tibiofibular joint. Now this is a very important joint as well. Honestly, what you can see here is we have, again, a posterior and an anterior distal tibiofibular ligament. We're also going to have a crural interosseous tibiofibular ligament. All that means, again, says what it is what it says. Break down the words and understand what the words mean. Also understand what motions that ligament is going to limit when it comes to our fibula and our tibia. So now here's the clinical implication. I'm sure you have heard, if you watch sports or see it in the news, something called a high ankle sprain. And for years I never understood what a high ankle sprain was. What a high ankle sprain is, literally the technical term is a tibiofibular syndesmosis, which means that the anterior and posterior, sometimes both, sometimes one or the other, those tibiofibular ligaments have been strained, torn, ruptured, and you can actually see the changes on a plain film radiograph. So take a look at the right hand side of the screen, and what you can see is that tibia sits out a lot wider than what it should be. On the left hand side of the screen, we're seeing what a normal is. Right hand side of the screen, that is the radiographic description of a high ankle sprain. Moving on to the interosseous membrane, again, says what it is what it says. It's a membrane between two bones. What it does is it serves a couple different functions. One function is that it serves as a site for muscular attachments. The other function is that it separates out something called compartments, and we're going to get into compartments just a little later. Understand the proximal aspect of that aperture. We're going to have a branch, or I'm sorry, we're going to have an aperture, an opening for the anterior tibial vessels. Remember that anterior tibial artery is going to pass through to provide blood to the anterior compartment. Also, we're going to have an aperture at the bottom or the distal end of the interosseous membrane, and that's going to be for the fibular artery. So now looking at the crural fascia, just understand what fascia is, understand the purpose of fascia. I'm not going to get into a ton into fascia in the context of this course. Just understand where it is, understand what it covers. Fascia is like this big thick sock that covers the entire body, and the part that's at that section, the lower leg of the body, is called the crural fascia. For this section, really spend some time with this section. This is probably the most important section of this piece of content. You have to know your compartments. Understand that we have 4 different compartments in the lower leg. We have an anterior, we have a lateral, and then we have 2 posterior compartments, a deep and a superficial. Very important to know what structures lie in each of those compartments. And then what you're going to see is you're going to see that there's a lot of commonality between them. They have common functions, they have common innervations, they have common blood supply. But it really starts with understanding where those compartments are and what structures are contained within those compartments. So the anterior compartment, what we're going to see with the anterior compartment is that it's going to be separated from the lateral compartment by the anterior intermuscular septum. Now there's a couple drawings, a couple supplement videos on this entire section. I want you to go through those. So in fact, pause the slideshow now and go back through those and draw these out. That's really going to be the best way to understand this information, is to draw it out and interact with it. Anterior compartment, like I said, common themes are going to emerge here. Here's the common theme for the anterior compartment. The muscles that dorsiflex my foot and assist with inversion and eversion or extension of the toes are in that compartment. Here's the other commonality. They're all innervated by the same nerve, which is the deep branch of the fibular or peroneal nerve. Quick note on difference between fibula and peroneal. Fibula is Latin, peroneal is Greek. You're going to hear me use those terms interchangeably, but understand they're synonymous. Now moving on to the lateral compartment. Lateral compartment is going to be separated from the anterior by that anterior intramuscular septum. The lateral intramuscular septum will separate my posterior from my lateral. In general, these guys are going to evert my foot. They're going to take my foot out. They're also going to share a common innervation, which is going to be the superficial branch of the fibular nerve. Look at this slide, look at the next slide as well. The superficial posterior compartment. This is going to be obviously my more superficial section. My muscles here are going to be my gastrocnemius and my soleus. They're going to be innervated by my tibial nerve, primarily going to be ankle plantar flexors, and also they're going to have a little bit of foot inversion as well. So just understand that. Also understand that my deep transverse fascia is going to separate out my deep posterior compartment from my superficial posterior compartment. So understand that concept as well. The deep posterior compartment or posterior compartment, again, separated out by the deep transverse fascia. This is going to be my Tom, Dick, and Harry section. Okay, so tib posterior, flexor hallucis longus, flexor digitorum longus, that's where this group lives. Okay, so understand that. Understand that they also are going to get innervated by the tibial nerve. However, those root levels are just a little different from the superficial posterior compartment. So again, go back to the other slide for the superficial posterior compartment, understand the commonalities, but then also start comparing and contrasting some of the differences. Now I fully understand this picture is a little bit of a shock. Okay? Here's the reason I'm putting it up there. Watch out for compartment syndrome. Compartment syndrome will come into your clinic. Compartment syndrome will look like a stress fracture. Compartment syndrome will look like an ankle sprain sometimes, or some sort of weird tendonitis. Understand compartment syndrome. Also understand there's two different types. There's an acute, like type 1 or first type, which is due to trauma. Usually someone got in a car accident or something, or some sort of like something hit them. And there's another, and this is the second one is the one that really is sneaky, because that's the chronic exertional type. Chronic exertional type is that person that runs cross country and feels like their leg gets really tight and really swollen after about a mile to a mile and a half into the run. That one, and along with the other one, are both medical emergencies. So be very, very careful for that. Now, taking a look at a little study hint here, okay? Again, look at the sections, look at the different colors, because all that's going to really play into what is those compartments and also the contents of those compartments. Understand that. So as you are studying this material, start really asking yourself, okay, I'm in the anterior compartment. What do I know about it? Boom, I know these things. I know that deep peroneal nerve innervates it. I know that they're primarily dorsiflexors. Okay, I'm in the lateral compartment. What do I know about that? Oh, that's going to be superficial peroneal nerve or superficial fibular nerve. Oh, I know they're mostly everters. Okay, good. Move on. So that's how I want you to start studying for this. If you understand it as a group and kind of chunk the information, you can actually study and understand the material much more efficiently. So take a look at this. This is a cross section, okay? This slide goes exactly with the last slide. Again, cross-section is a great way to understand not only structural anatomy, but also functional anatomy. Now, study hint here, first thing you got to do is figure out what part of the body you're in. So if you see a cross-section and there's one bone, chances are you're going to be in the femur, okay, or you're going to be in the thigh. If you see two bones, chances are those two bones are the tibia and the fibula. Okay, so that's the first thing you have to do. Then from there, map out your compartments. From there, start mapping out contents, both from a myology standpoint and a neurovascular standpoint as well, and then start looking at function. Okay, I think that's really the easiest way to learn that material efficiently. So in looking at the anterior compartment, start noticing commonalities here. Okay, what I want you to do is I want you to pause this slide and I want you to draw out those structures. Okay, color them in with a coloring pencil or a set of crayons or markers or whatever you got. And I want you to start drawing in those structures, because what you're going to find is on the proximal aspect, everything's going to look like a big bunch of mush, as you guys saw from Cadaver Lab. Start getting into the distal aspect, and I can start tracking those tendons, and I can realize and I can see where those tendons go. That's going to give me a lot of clue for not only what the function is of that muscle, but then obviously the name of that muscle as well. Now, looking at the lateral compartment, again, a lot of commonality here. Notice that my fibularis longus and fibularis brevis both track posterior to the lateral malleolus. That should give you a lot of clue, because what I want you to think about is, okay, if I contracted that muscle, if I pulled on the tendon from distal to proximal, what would happen? Well, obviously the ankle will evert, but it's also going to plantar flex a little bit too, because obviously we're posterior to the lateral malleolus. So we need to understand that. We need to understand how that muscle acts, and that's going to give us a lot of clue to what that muscle is. Also, looking at the lateral compartment, remember that the common fibular nerve is going to split into the deep and the superficial branches. Our lateral compartment will be innervated by the superficial fibular nerve. Looking at the posterior compartment, a lot of commonality here as well. Obviously, like we talked about before, we're going to have two different posterior compartments: a superficial, which is what you see on the left-hand side of the screen, and a deep, which is on the right-hand side of the screen. Very important to know the attachments, obviously, for all of that myology. Also, when it comes to the deep compartment, understand that the orientation of the Tom, Dick, and Harry muscles at the proximal end is not their orientation going through the tarsal tunnel. We're going to get into the tarsal tunnel when we talk about foot and ankle, but just understand that their orientation changes just a little bit. So be very, very aware of that as you're going through your study. So now, take a look at this chart. This is obviously one of the many charts we've gone through. I think these charts are very helpful when it comes to making connections in the material. Understand planes of action. Understand planes of motion. So what we're looking at is, and the reason I want to go over this, is that we're not going to see our typical terms when it comes to flexion, extension, abduction, adduction. The ankle is very different. When I move my ankle up, or when I move my foot up, if I'm sitting towards the ceiling, that's going to be dorsiflexion. Pointing my foot downward, like pushing against the gas pedal, is going to be plantar flexion. My frontal plane motions are going to be my inversion, which is kind of curling my foot under, and eversion will be taking my foot away from the midline. Now, grouping by region, take a look at the muscles. Again, this should look exactly like that cross-section did. So understand each of those muscles grouped by a region, understand how that grouping works, and how you can use that to your advantage. In looking at this chart, now we're grouping those muscles by innervation. So, like I said before, our different compartments are going to have different sources of innervation. So there are a lot of commonality here as well. So what you should see is, okay, I'm seeing a pattern here. I'm seeing a pattern between the compartment, the structures, the names of the structures, the motions the structures do, and when I'm talking about myology, the innervation patterns, and then we're going to add on blood supply as well. And lucky, they have good patterns as well. So another chart, if you haven't seen enough charts yet, but this chart, again, very important. This is their action chart. So take a look at what muscles perform dorsiflexion, which perform plantar flexion, which perform eversion, inversion, and then flex and extend my digits. What I want you to do is I want you to pause this slide, and I want you to circle out all those muscles that perform dorsiflexion, plantar flexion, inversion, eversion, digital extension, digital flexion. Then I want you to go back and I want you to say, okay, which of those muscles are in which compartment? You should see a lot of commonality, but you might see a little bit of difference as well. But I want you to understand those relationships. So in looking at attachments now, understand the differences and understand all of the commonalities between each of the attachments. Take a look at what attaches the back of my femur. Gastrocnemius and plantaris. That should give you some clues of what those muscle functions are. What attaches to my tibia? What attaches to my fibula? What attaches at my tarsals? Again, those should all give you a lot of clues. So as you're going through these, this is a great way to study because you can start drawing these structures out, and then you can start laying on, oh, I know what happens there because this muscle attaches to this bone. That's going to give you a lot of clue when we start moving into foot and ankle motion, which I will say is a very difficult subject to master. So now looking at retinacula. So what we're going to see is we're going to see something called an extensor retinaculum. Many of you have already seen this in cadaver lab. So what this is just a thickening of the fascia. Its job, just like we saw in the upper extremity, is to hold down all those tendons so we can have a better line of force or a better line of pull. This is your fibular or perineal retinaculum. There's two different parts. There's a superior section and an inferior section. These guys serve the same purpose as the extensor or the dorsal retinacula. Just understand where each of those attach, and then think about what muscles are going to ride underneath of that retinaculum. So now, obviously, we've had an extensor retinaculum, we have a lateral retinaculum. Hey, why not have a flexor retinaculum too? So what this is going to do is attach my medial malleolus. Remember, that's the distal termination of the tibia, and it's going to attach into the posterior section of my calcaneus or my heel bone. And understand the tendons it's going to cover. So you can see from the right hand side of the screen, now we're starting to form this section of the body called the tarsal tunnel. Obviously we saw a carpal tunnel in the upper extremity. Now we're going to have a tarsal tunnel. My tarsal tunnel is where that Tom, Dick, and Harry reference comes in. That's exactly why we're going to have this retinaculum, because it's going to form the hood over top that tarsal tunnel. So now looking at the artery supply, the blood supply to my lower leg. I have a supplement video on this. I actually have a couple of them. So I want you definitely to look at those supplement videos. Understand that my popliteal artery, remember that's going to be a continuation of my femoral artery. Femoral artery passes through the adductor hiatus, and then it's going to split into the anterior and posterior tibial arteries after it passes behind the knee as a popliteal artery. So just understand that. My suggestion would be draw these things out. Understand those relationships. So quick shout out to the veins. Understand the slide. There's a lot to read on the slide. I'm not going to read it to you. Just understand where those veins occur, understand what those veins are called, and understand how those veins drain back into something like the inferior vena cava. So nerve supply to the lower leg. Obviously what we can see here is our superficial and deep fibular nerves. Remember, those are both a bifurcation of the common fibular nerve. And understand where those go. Like I said, if you know the compartments, you're going to pretty well understand the innervation. My superficial fibular nerve is going to supply my lateral compartment, and my deep fibular nerve will supply my anterior compartment. Cutaneous innervation is going to work very, very similarly. So when you understand cutaneous innervation, obviously the first thing that should come to mind is dermatomes. So understand those dermatomes. Understand where something like the saphenous nerve lies. Okay, that's going to be my medial to anterior medial lower leg. That comes from the L3 and L4 nerve roots. So understand not only where that dermatome comes from, obviously if you test that dermatome, what those findings mean. Now the posterior aspect is going to have something called the sural nerve. Now that's going to be a branch off of the tibial and common fibular nerves. And understand again where that innervation happens. Understand the difference between where the common fibular nerve cutaneous branches are. Understand where the sural branches are as well. So looking at the superficial fibular nerve, this is a little better look at it. So just understand, and this is actually a nice chart where you can see each of our cutaneous nerves. You can see exactly where you're going to test those. That becomes a very, very big deal when it comes to patients that have suffered car accidents, lower back pain that has some radiculopathy, even things like diabetes, where we really need to understand what nerves are involved. So with that, thank you everyone for your time and attention. Remember, look at this section, combine it with the knee section, and then look at this section and combine it with the foot and ankle section. That really is going to be the best way to study this material.